Good morning, everyone. My name is Monica, and as a clinical program manager at InBody USA, I want to welcome all of you to today's webinar in our InBody Present series. Today, Dr. Rony Dev will be speaking to us about cancer cachexia and the current use of bioelectrical impedance in this application. Dr. Dev is board certified in internal medicine and palliative care. Currently, he is an associate professor in the Department of Palliative Medicine and is the director of the Cachexia Clinic at MD Anderson Cancer Center. He has published in numerous journals regarding treatments for cancer cachexia, communication in family meetings, and risk factors for chemical coping and addiction in patients with cancer. He provides palliative care consultations regarding pain and symptom management for patients with cancer. During the talk, as well as after, attendees will have a chance to ask him questions by adding them to the Q&A section on your screen. Without further ado, I'd like to welcome our guest speaker, Dr. Rony Dev, to join us.
Hello, hi, everyone. I'm going to talk about our experience with the InBody machine at MD Anderson Cancer Center. We obtained one several years ago, and currently we have two InBodies that we use and incorporate in various research projects. Briefly, I want to give a background why it's important to assess weight and more specifically body composition. First slide, again, cancer cachexia is a multifactorial syndrome. It involves the loss of skeletal muscle mass. It may or may not, patients may or may not lose fat loss. And in some cancer patients, such as leukemia or breast cancer, you actually see a loss of skeletal muscle mass with an increase in fat loss. And that's why body composition is critical to assess. Unfortunately, patients with cachexia, conventional nutritional support is unable to reverse weight loss, and very often is associated with fatigue and functional impairment. And if you look at the frequency of cachexia in a palliative care patient population, it's up there with pain and fatigue, and weight loss and loss of appetite is a very common symptom, especially in advanced cancer patients. And in the past, older studies is tumor dependent. However, breast cancer patients and even leukemia patients may have alterations in body composition, which can be problematic as well. Leukemia patients can also have problems in skeletal muscle density and various things. The current definitions for cancer cachexia previously is greater than 5% weight loss over 6 months, or greater than 2% with a body mass index of less than 20. And unfortunately, what we see in our at least our cancer clinic is patients may have had a prior history of weight loss, and once started on treatment, they may stabilize or even improve. The time period, I'm not quite sure if it's as relevant to, and sometimes we ask a past history, and the vast majority of patients, unfortunately, especially our solid tumors, have lost weight. More recently, the idea of stages where you have pre-cachexia, prior to cachexia, and refractory. And I think the significance of this is that interventions like omega-3 fatty acids are more effective in the pre-cachexia stage. As you approach the refractory cachexia stage, interventions become less effective, and psychosocial support becomes more important. And the distress from weight loss is not just patients, but also family caregivers, And it's not uncommon that you have caregivers requesting feeding tubes or TPN in cancer patients, which unfortunately are not always effective, and so it causes distress in patients and family. And other outcomes with loss of weight, shortened survival, impact treatment decisions, increased morbidity, decreased quality of life, and again, patient and caregiver psychological distress. And this is kind of a crude picture of how cachexia can also cause death. It affects the immune system, increased inflammation, autonomic failure, and a host of other things that can contribute to patients passing away. One thing we do in our clinic, and most clinics do, is looking at change in weight and BMI. This was a group in Canada that looked at these two factors, and on the section B, you have the survival in months, and both BMI and percentage weight loss associated with worse survival. More weight loss, worse survival; less BMI, you get worse survival, and they have prognostic indicators with those two outcomes. Treatment for cachexia is challenging, and this is, I encourage our patients to enroll in research studies. The foundation is exercise. Frail patients, it's difficult to tolerate. About 30% of our patients are able to tolerate gentle exercise, and nutritional counseling, working with a nutritionist, assessing symptoms like pain, nausea. You can't get patients to take in more caloric intake without providing quote unquote best supportive care. And there's various appetite stimulants that are out there, and also treatment directed at inflammation, hypogonadism, low vitamin D, endocrine dysfunction, which might be contributing to fatigue and possibly body composition. And then supplements with certain amino acids can be beneficial. Preliminary studies are mixed, and then there is concern for cancer metabolism that some supplements actually may be fueling cancer. Unfortunately, more research is needed. It's a complicated problem. So I'm going to focus on assessment. Why is assessment important? You have two patients here. The patient on the right is a patient of mine who is admitted in our inpatient palliative care unit. By looking at him, you would not necessarily say he is cachectic like your traditional picture of cachexia. But this patient had a significant history, greater than 50-pound weight loss, history of lung cancer, and was admitted to our unit for pneumonia treatment. Unfortunately, he recovered from pneumonia. He's ambulating with physical therapy, but unfortunately, after discharge into the community, he passed away after 2 weeks from when this picture was taken. Different assessment tools that we use, more so in the research setting. In our clinic, we do check the BMI and weight loss trajectory. Research FAACT, they have an anorexic cachexia subscale. Appetite, diet diary, more in a research setting. The ESAS we do on all our patients, as well as treating other symptoms that impact nutrition. In the research setting, biological markers can sometimes be helpful. For the screening tools for malnutrition, we often use the PGSGA, and then resting energy expenditure that involves indirect calorimetry. But one thing I think is critical is body composition, and not just in research, but in clinical practice. We currently are doing a survey of all our patients to see the impact of cachexia. Currently, we do the bioelectrical impedance analysis for body composition in our cachexia patients only who see us in the cachexia clinic, but hopefully we're going to assess all patients. And then other things, anthropometric methods in the past were used, CT and MRI, DEXA, previously considered the gold standard, but the cost and logistics and exposure to radiation from CT scan can make it a challenge. And then here's a slide with the CT scan. Using things, there's several software programs. We previously using Slice-O-Matic and as different programs at a certain section of the L2 or L3 lumbar skeletal area. Software can be used to highlight the muscle mass, and you see two patients with the same BMI having patient A obviously having more lean muscle mass. And unfortunately, CT requires, again, exposure to radiation, and the cost of doing this is not always easy, mainly used in the research setting. The InBody is useful. Well, we find it useful and convenient. Many of our patients are very frail. The vast majority are able to get assessments with assistance with our nursing team in our clinic, and you get your skeletal muscle mass, you get your lean muscle mass, and your body fat mass. Also, you get the overview of the change in body composition over time, which actually our patients, once they get their first assessment, they often are curious to see how things are evolving. And then the phase angle has also been reported as a prognostic tool. And we've done several studies on single frequency and as well as the multiple frequency machines that show the phase angle being correlated with prognosis. The challenge obviously is communicating that to patients, and it's a delicate discussion. There's multiple studies have been done, just the recent ones looking at multi-frequency and acutely ill hospitalized patients. The video also had references to a few studies as well, and percentage assessing body fat and parental nutrition. This is also surgical patients after surgery for colorectal surgery, comparing with CT scans. The second study comparing with DEXA, and the multi-frequency has held up reasonably well, and again less invasive and less costly. In the past, we again done the phase angle. The challenge with prognostic information again is disclosure to patients. Some patients are more receptive with open disclosure. Some patients may not necessarily want to know the best educated guess, and it makes prognostication a little easier when you have the confidence with various data. And Dr. Hui does a lot of studies with various prognostic algorithms. We also did a study, Dr. Yunu does our cancer fatigue with Anna Morellin using the InBody. They're looking at multimodal for fatigue as well, multimodal interventions, and then showed improvement in lean body mass. Unfortunately, Anna Morellin is not approved in this country. In Japan, it is approved, and had a recent talk in Japan that's frequently used. Unfortunately, anorexia itself, there's many factors that cause people to not eat, and can help in some patients, but not all patients. And then the issue of sarcopenia or frailty in our rehab patient population is also important to assess muscle mass. And then in conclusion and summary, I think anorexia cachexia syndrome is very important. It often gets neglected. The focus on pain management and other acute symptoms but loss in lean muscle mass and changes in body composition have big impact in quality of life, functional outcomes, and even mortality. I do think assessment is very important. Some of the challenges with COVID, patients physically weren't present, and the lack of information, I do think we provide less care with telemedicine. It's important to at least assess patients periodically, physically, with things like body composition and assessments of the weight. For the most part, the InBody is feasible in critically ill or frail patients. We feel it's easy to use. There was in the past some concerns about various ethnicities, and the InBody team sent the recent journal article which shows that the accuracy compared to DEXA and CT scan was actually pretty good. Of the two multi-frequency machines, it looked like the InBody did better than the other machine that was discussed in the paper. And so I think for the most part, our group has been very pleased with the data. It actually gives a lot of information that we're still in the process of assessing, and so we do find it useful. I'll kind of open to any discussions or questions.
Thank you so much, Dr. Dev, for sharing the work you are doing with us. At this time, we would like to take some questions from our audience. As a reminder to all attendees, you can send in your questions to our speaker using the Q&A chat box at the bottom of your screen. So let's start here with some questions, Dr. Dev. You discussed that pre-cachexia, losing less than 5% of your body weight or lean body mass, is a better indication to actually start treatment for many patients. Would this amount of weight loss be considered during a certain period of time, similar to the 6 months you mentioned earlier? Or do you believe, based on your experience and maybe recent research work, that a time frame is really not the best parameter to use?
Well, our patient population, we find kind of an interesting fact that patients, at least in the immediate 6 months, may be gaining weight, but if you take a more in-depth history, longitudinal history prior, you find that they had already lost substantial weight at the initial time of diagnosis, which may have been 5 years ago. And so once a patient, let's say, is losing more than 5% of the weight, they're in a catabolic state, and even though they may be stabilizing the last few months, they have already lost a lot of muscle mass, and so I do think it gets troubling. The other issue with the obesity epidemic in the country is that sometimes patients, prior to the diagnosis of cancer, they're losing weight, and whether they're dieting or on ketogenic diet or intermittent fasting, they're actually happy with the weight loss, and then unfortunately develop cancer for other reasons, and they have lost a considerable amount, and it becomes challenging to reverse it. Multimodal treatment is being researched. I know the group in Italy has good success with using more than 2 or 3 interventions. In our clinic, it can be a challenge to treat cachexia, so I do think trying to assess it and treat it earlier is important. And that window of 6 months, what we try to do is ask our patients prior to the cancer what was their maximum weight, and try to get a better idea of how their weight has changed over time. And so try to have more of a longitudinal picture of weight loss.
I understand. More of a personalized approach to how to treat them.
Yeah, I think the personalizing is the key, just because there's so many different factors to weight loss, or just taking anorexia, for example. And you see in the studies, like medications, Strasser's study on cannabinoids was negative, but there's other studies where you have a small subset of patients that may benefit from medications like Marinol, which unfortunately has a poor absorption, but there are some patients for unclear reasons, maybe the cannabinoid system is more of a key role for why the patient is anorexic. Again, even things like steroids or other medications. And then things like anti-inflammatory medicines like Celebrex, which are used in many centers, or omega-3 fatty acids. I think Dr. Baracos' group in Canada had a couple of studies where fish oil, when used earlier, had benefit. When you get to the refractory stage, we have frail patients, asking them to use more than 1 or 2 interventions along with the therapy that they're getting for their cancer. The polypharmacy, it's challenging for patients to comply with multiple interventions.
Yeah, definitely. One of our attendees is asking if you can give more detail about the phase angle. How do you use it? How it works for as a prognostic factor?
I think David Hui does the phase angle. I mean, my kind of a crude assessment that it's an indirect kind of a assessment of cellular integrity, and as patients get sicker, it tends to be the cellular integrity, it tends to be compromised, just kind of like CRP or inflammation. And so I think in the article they outline how the phase angle can be used. There's various prognostic tools that he kind of goes into, and formulas. We have kind of a web-based prognostic information that collects various information and puts it in kind of a formula to give a rough estimate. The most recent paper that he did, the information is helpful. It kind of reinforces the prognostic information provided to patients from a palliative care provider. But in general, our educated guess is actually not too bad. I think things like CRP and other things like phase angle and other laboratory things that have been associated with poor prognosis kind of reinforces our assessment. Weight loss by itself is a prognostic factor, and then loss of lean body mass, I think, is a good prognostic factor. It's the broad performance status, and I think you have to kind of combine things together, and but it does reinforce or makes you a little bit more secure in your information that you provide to the family.
Thank you so much, Dr. Dev. You mentioned that 30% of your patients are able to tolerate light exercise. Is this only with severe cachexia, or are you seeing this across the board? In addition, what is meant by not able to tolerate? Are you seeing the patient prognosis getting worse with exercise in the patients who cannot tolerate?
Exercise is challenging. I think, again, the key thing is personalization, and we've been looking at why some patients are more compliant than others. One, I usually try to find out what patients had enjoyed. Now, there's unclear unclear whether aerobic exercises versus resistance exercises is superior. There's some evidence maybe aerobic might be a little bit better, but in terms of aerobic exercises, our rehab colleagues try to target 3 to 4 times per week. With resistance exercises like band training or resistance training in the water, which I find appealing, it's usually about 2 to 3 times a week at the most, and we try to emphasize that you're not necessarily trying to run a marathon or try to build massive muscle. We're just trying to stimulate the body with exercise, and it is unfortunately a myth that the one exercise causes weight loss. You have to exercise a lot to result in weight loss. We're just doing gentle exercises that patients find enjoyable, and trying to get either a prescription or ideally for patients who can afford it, a personal trainer, trying to pick a activity that they enjoy. If they like to be in the park, walking in the park for 30 minutes. And again, I do try to tell my patients that it's stimulating and it's actually either neutral or positive for symptoms like fatigue, and trying to stimulate the muscle and maintain muscle mass, trying to prevent deconditioning. Why some patients are more compliant, I don't know if I have the answer for that. We're trying to work with our rehab colleagues to try to see what interventions will improve compliance, and then each patient may have certain restrictions, lymphedema, and I think the InBody, we don't use it for as much for the lymphedema. I need to talk to the rehab colleagues, but it can also help with water retention and various arms or legs, and so that possibly can be useful for that as well. But patients have various restrictions, and we have to personalize it to what they can do. For very frail patients, we have some information on exercises they can do when they're sitting with band therapy, and working with our physical therapist, I think is very useful. Hopefully we'll have more information in the future what intervention improves compliance, at least in our patient population.
Yeah, it'd be great to know what helps them more to recover a little better, right? Also, they're asking, how often do you find it most effective to measure your patients for cachexia in the clinical setting, or is this done only for research purposes?
I'm sorry, how often do we
you actually measure your patients for cachexia? How often do they come and get monitored for cachexia?
Well, typically, I think there was the diagram with our multimodal treatment for cachexia. We tried to see patients on a monthly basis. Typically, the nutrition counseling in most of the studies is twice a month, which is a little too intense for our patient population. Typically, the patients that are very motivated to do the multimodal, we do try to see them on a monthly basis for at least 2 to 3 months to make sure that they're going in the right direction, and then depending on that, we can alter the frequency of the interventions. One of the first things we do that I think is critical is what's called best supportive care, is to treat the pain, nausea, things like constipation, kind of the bread and butter of palliative care, so that the analogy that my boss uses, Dr. Barrera, you have someone with cachexia, basically the factory is not working, and if you still put in raw material, you're not going to be making anything. So if you're still feeding people with calories and the body's broken, then it's not going to be processed. So it's important to treat the pain and treat the nausea, treat the motility issues, treat the constipation, treat mood disorders, which can contribute as well. And so we're having a kind of a debate about having separate cachexia clinics, but I do think that quote unquote best supportive care is needed for these patients. And what we find is that it is a little bit more intense to do the multimodal, that patients are motivated to follow up with us, go to the cachexia clinic. Unfortunately, some patients who are true frail, they may be seeing our supportive care providers, our palliative medicine providers, but I do think there is a whole group of patients that have weight loss issues or loss of lean body mass that are being neglected, and so it's something that we need to probably look at a little bit more commonly. My hope is to screen all our ambulatory patients for not just the weight loss using a malnutrition questionnaire, but at least having a baseline InBody or body composition assessment, so that in the future, if there are changes, we have a reference for all our patients, and that's the current cachexia survey is looking at that. We're midway through 70 patients, 70 patients and dyads, including their caregivers. We're also assessing caregiver distress. Hopefully, by the end of the year, we'll have a better idea of how, taking a broad picture of how frequently patients are, one, have decreased lean body mass, two, how much distress they have in patients and their caregivers, nutrition impact symptoms, and other things. We already published a study on patients just in our cachexia clinic, but we're hoping you see all patients and see what the frequency is.
Yeah, that definitely will be great to see. Here, Dr. Dev, you mentioned pain related to cachexia and how improvements in cachexia can improve fatigue. And we have seen from previous researchers that it can be related to improvements in face angle, for example. But I believed before pain was intrinsic to the disease, not to factors like cachexia. So is it always the case that pain can be significantly improved for patients, or does it also depend on other factors?
So you're asking about fatigue or pain?
Mostly pain, because I thought it was just because of the disease they're going through. But I think you are saying it's also related to cachexia.
Yeah, well, I think symptoms are interrelated, and I think that's one reason we do the ESAS. The mood affects caloric intake. Pain can indirectly affect the caloric intake. Sometimes you have something more direct, meaning you have pancreatic cancer and patients are having difficulty digesting fats, and they may need their supplements for their enzymes, pancreatic enzymes, to be adjusted or titrated, or so even fatigue. Pretty much all patients with cachexia will have fatigue. Not all fatigue patients will have cachexia, and so there's this relationship with all these different pain symptoms that contribute in some way. Sometimes it's very direct. An extreme example is mucositis, where you have oral pain, and that shuts down oral intake of calories. And when you look at patients that have bypass with a feeding tube, it may reverse the weight loss to some degree, but patients continue to lose weight, like head and neck cancers. And so all these symptoms need to be assessed and looked at together, and also prioritized. I think it's important to focus on your acute symptoms before you can move into the cachexia or the other advanced care planning type issues. So if you're in a pain crisis, that often needs to be addressed before you can even assess the body composition issues and things like that. And I think Dr. Barra has a nice slide of the acuity of these various symptoms, but I do think that they're all related in one way or another. Now, some patients, it may be a big contribution to decreased caloric intake. Others maybe having ankle pain from osteoarthritis, that may not necessarily have a big impact on cachexia or caloric intake. So it's quite personalized, and that's why in some ways randomized controlled trials for our type of patients, if you look at a group of patients and a certain intervention, you see a lot of negative studies, but there's subset of patients that may benefit from, let's say, Marinol or fish oil or exercise intervention. And so it's trying to learn about the patient, personalize the treatment, focus on the acute symptoms, then moving over to things like the cachexia, body composition, and then the emotional issues. And then also once those things are sorted out, also addressing advanced care planning. And so a bit time consuming, but I do think that they're all related.
Yeah, so a lot of different parts moving. One of our attendees is asking if you actually use segmental information for your practice.
Medical information?
No, segmental information. Like the body composition will give you segmental information for each of the limbs and the trunk. Do you use any of that information for your practice?
I apologize. The information about the lean body mass or the
well, or more of like the segmental lean body mass or the intracellular water or extracellular water in each of the limbs, for example, or the trunk that may show you inflammation, things like that.
Yeah. Well, we look at all, especially the changes in the different lean body mass, fat mass, and I think that's critical to see. And what our patients, if they're doing certain interventions and they see improvement in their lean body mass with serial measurements, they get more motivated to go with our clinical interventions, and you see that in there. Once they do the InBody, it's been a little bit logistic challenge with COVID because we're doing telemedicine, but once they do the InBody, they're very eager to do it again, especially if they're concerned about their weight. And you see that it kind of reinforces their commitment if they see actual changes from month to month of their body mass and things like that.
Thank you. Yeah, that makes sense. One of the attendees is asking, why is body mass index still used when percentage body fat is considered to be more accurate?
Well, I think the BMI is just available and it's simple to do. There is a small subset of patients that they're too frail to get up onto the machine, but it was in our experience, and we have a good majority of frail patients. Most were able, with the assistance of our nurse, to get the assessment. The BMI by itself, I think, is still helpful. It's still independent prognostic tool, just as the percentage weight loss is also a prognostic tool. I think in the future we'll have more information. What I find interesting with body composition is that lean body mass and even fat mass. Fat is not necessarily an inert type of compartment. There's hormonal changes and other changes that have implications, and vitamin D is kind of stored in fat compounds. The ratio of testosterone to estrogen, the composition of lean body mass as a percentage of body fat. Dr. Dalal has looked into body composition in breast cancer, and one of my other colleagues, Dr. Del Fabro, we looked at body composition in various other cancer types. And the implications of fat, it's not so simple. It's probably a lecture in itself. And I do think just because BMI and percentage weight loss is easily available, it's just something that is traditionally done. And I think Prado, who did a lot of the CT body composition, they even have research showing how it can impact the dosing of chemotherapy regimens. And these are older studies. And despite having all that data, it takes time for people to integrate this knowledge. I mean, on average, several years. It often is delayed to integrate it. And we do have challenges with the amount of information. What we get sometimes is overwhelming, and so trying to find out exactly what is the most useful is something that we're trying to look at for our palliative colleagues and our rehab colleagues. And it's still, BMI and the percentage weight loss over time, it still has some utility. I think the next step, since it is time consuming, but the next step is looking at body composition, looking at more subtle things, changes in hormone, things like ghrelin and leptin, CRP, and other things that should be assessed and may be useful in the future. For an example, it might be like ghrelin, leptin, which patients may benefit from a medication like anamirolin, which is a ghrelin agonist, as opposed to something else. And the assessments like body composition and these lab abnormalities are a little bit more intensive. They're usually done in a specialized clinic, and I just think that things are being delayed. It takes time for these novel things to be integrated into therapy. We initially got the body composition machine several years ago, and so it just we've grown quite as a practice. When I started here 16 years ago, we had 5-6 physicians. Now we're at 26 physicians, and equal number of APNs, and it's hard to, all the knowledge that's being produced is hard to apply it clinically, and that is a challenge.
Yeah, definitely it's a challenge. Just because you mentioned that with some patients they're very frail, sometimes to stand in the device, just remember that you probably already know that there is one that you can actually test them supine, so it's more comfortable for them. So eventually, if you want to look at the body composition, you can also do it that way for more frail patients. Here there's another question from the attendees. Have you observed any relationship between the psychological interventions and improved cachexia, lean body mass, edema, for example?
Any connection between
psychological interventions?
Psychological interventions and lean body mass. Well, yeah, there is one, obviously depression having an impact on oral intake, and mood abnormalities can either increase or decrease intake. You see certain cancers like pancreatic cancer have a high frequency of clinical depression, and there's some basic science like even medications like Cymbalta for mood. These were more in animal models where the norepinephrine blockage from Cymbalta actually prevented the cachexia in animal models, and so treating the mood is one thing. From another perspective, body image distress. One of our research colleagues, Wadi, had looked at body image as well as other groups, and it's quite high. And what we do is we have our psychology team help with those types of issues, so mood abnormalities do have an effect, and sometimes the medications we treat for mood can either increase or decrease appetite. Sometimes medication like mirtazapine, which is we like because it helps with sleeping and tends to promote weight gain, might be selected over other mood medications, and so that is a complicated thing. Other issues with caregivers. One of the most difficult conversations is talking about nutritional intake, the request for parental nutrition or feeding tubes or TPN. And unfortunately, there may be a small subset of patients that benefit from TPN. Most patients with cancer that are getting active chemotherapy, the risk for infections and other things, it unfortunately is not there. But distress in caregivers sometimes results in the medical teams doing feeding tubes and things like that. So again, there's a lot of interconnection with the patient's caloric intake and body composition and emotional distress with all these things.
Yeah, it's very, very interesting to see how different things have integrated now, right? And your and it has grown so much, right?
Yeah, we have an integrative medicine team, and there are some acupuncture for anorexia is a little bit mixed. There was a small study actually showing that it improved ghrelin sensitivity. And the studies on acupuncture have been probably better for pain, there's a dry mouth, nausea. Anorexia has been mixed, but using the integrative approaches is something that we try to incorporate as well.
Very nice. There is one question here, the last question I'm going to give you for today from the attendees. Do you find any significant changes in face angle readings during treatment?
Oh, that's a good question. Phase angle over time. That's actually a very good question. I don't believe we looked at that. That would be interesting to see if patients who respond to treatment and with immunotherapy, it is not necessarily a home run, but some patients that we have with lung cancer and other cancers, how quickly you would expect it to change when patients do respond. You would expect the cellular integrity to improve. I don't think we've done a serial study. But that's a wonderful idea and suggestion.
Yeah. I know with regular cancer rehab in different stages, they have shown doing chemotherapy to remain steady or improve a little bit, and rehab and after survivorship, it improves. But yeah, it will be very interesting to see in your population how that works. Dr. Dev, before we conclude, do you have any closing remarks you'd like to share with us?
Any questions from my perspective?
Or how do you see your future industry? How things are
for the future. I agree. I think the body composition is something that is probably overlooked, and even issues like cancer cachexia, it's a challenge. Our patients have a lot on their plate, a lot on their agenda, and you're trying to balance of trying to be too overburdening but I do think that the body composition is going to be an important assessment that over the next few years will probably see being incorporated. The other thing that I see with cancer patients is hormonal alterations that I think get overlooked as well. And you see immunotherapy, especially altering various, whether it's adrenal gland or thyroid and other issues. You see that with targeted therapy as well. And they can considerably affect not just weight, energy level, and other things. And I think that's there's a lot of room for improvement in assessing these things and addressing them with various interventions and treatments.
Thank you so much, Dr. Dev, for taking the time to talk to us today. We are very grateful for you for sharing your research work and your clinic work with us. If you need to reach to Dr. Dev, please use the email shown on the screen. To all our attendees, we hope this was both informative and inspiring, and that you will consider joining us in future webinars. If you need to reach out to us, please contact us at clinical@inbody.com. If you want to have a conversation with us about applications, or if you may be interested in sharing your research with us and other researchers through this forum. Also, please contact us if you need a certificate of attendance to apply for CPU credits or CPE credits if that applies to you. And please stay tuned for our upcoming InBody Presents webinars. Follow us in LinkedIn for news on any other events and in our new next webinars coming up. We look forward to seeing you there.